Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode 203 of the Better Health Guy blogcast series. Today's guest is Dr. Richard Semelka, and the topic of the show is Gadolinium Deposition Disease. Dr. Richard Semelka has been in practice as a radiologist for over 28 years and is a world authority in body MRI, safety in radiology, and gadolinium toxicity. He is a leading published expert in radiology for body MRI and gadolinium toxicity and has made presentations at major meetings all over the world. Dr. Semelka has written over 370 peer-reviewed papers and 16 textbooks. He is the first doctor to publish on the entity of gadolinium deposition disease. And now my interview with Dr. Richard Semelka. I am excited today to learn about a very important topic, which is gadolinium deposition disease. And we have the world's expert, Dr. Richard Semelka, with us today. Thanks so much for being here, Dr. Semelka.
It's my pleasure to be with you today.
Talk to us about how you ultimately made gadolinium deposition disease, or what we may refer to as GDD, really the focus of your work. How and when did you first get this on your radar, and what drives your passion for the work that you do today?
Well, Scott, let me just back up a little bit on my involvement with gadolinium. I think, and it's funny, I kind of maybe say this in part because my work with GDD is a little bit like penance, but before recognizing the disease, I happened to be the leading author on the use of gadolinium on MR studies. So in some respects, when patients tell me, that I developed toxicity, incredible fasciculation, skin pain, and so on just after gadolinium, in some ways, if you like, Scott, feel a little bit guilty. So I think a little bit what drives me are two things. I have been involved in this, and I'm driven by truth. So how it started actually is in about 2017, a patient who, out of the blue, emailed me and said, at the time, I was the director of MR services, and I think also at that time, also the vice chair of quality and safety at University of North Carolina. So a patient emailed me out of the blue and said, I had an MR study at your center, and immediately afterwards, my skin is burning like I'm on fire. So I sent that to our risk management. They said, well, we did everything according to FDA regulations, ignore her. So what I did is I contacted her. So I contacted her and spoke to her about it. She was the first person that I heard this about, because prior to that, except for patients with severe renal failure, that in 2016, we knew that they can develop nephrogenic systemic fibrosis, NSF. And still to this day, I believe it's largely restricted to people who have severe renal compromise. So at that time, we knew that patients could get sick from gadolinium if they had severe renal failure. But people with normal kidneys, we thought, well, they're perfectly fine. In fact, words from other experts at the time, I recall, would say that gadolinium is as safe as water, right? So many radiologists were of that opinion, including myself. Didn't have renal failure, you wouldn't be sick. So there was her, spoke to her, but as I tell everybody with healthcare, you need to have one more example, because you never really know with one person, many different things can happen, right? So there was another individual, and then there was a vice dean in our university who said to me, "You spoke to me before I got an MRI, and you guaranteed to me that it was completely safe." 15 days later, I was on a plane with my husband, who's also a chairman in medicine at UNC, and I felt like somebody had taken a filleting knife and was cutting through my forearms. And after that, this was then 3 people who said that, and particularly this one that said that I told her it was completely safe before the procedure. I thought in my role as one of the leading authors in MRI, one of the leading authors on gadolinium, that I should be the one to speak out that there may be safety issues and we have to figure it out. So shortly after that, I wrote a paper that described the entity, Gadolinium Deposition Disease, and that more or less started everything. So it wasn't sort of just randomly me thinking, something may be wrong. I had direct experience with individuals and with people ultimately in the end that I knew that there was no possibility that they were trying to get something out of UNC and me. I realized there was a problem. And I thought, well, who would be better positioned than myself to really describe what the issues are? So that started my journey, which then over the last 7 years, I've evolved into a better understanding of the entity and also how it relates, more and more to the really incredible envelope of similar entities that basically are an immune system dysregulation. And early on, I'd like to mention the term that I like from the ancient Latin from Rome, abyssus invocat. One hell calls forth another. What I've learned more and more is that if somebody starts with some sort of process that has disrupted their immune system, they are a setup for getting another entity, one of which can be gadolinium deposition disease.
So from a timeline perspective, when was that first case report that you heard about negative response to gadolinium, and when was gadolinium first used in the medical field?
So my recognition of that people with normal kidney function can get a severe persistent reaction. Now, this is different than acute hypersensitivity reaction that we've known for maybe 30 years with gadolinium, maybe 40 years with iodine contrast in CT. So we've recognized that it exists, but a persistent reaction I didn't report on till 2017. And the use of gadolinium as a contrast agent in MRI started in 1989 in the US.
So going against the tide, trying to be an agent of truth in the world that we currently live in, I'm sure that is a difficult role to play.
Scott, well, I think you have some idea. Yes. It is an incredible role to play.
So let's start with some of the basics. What are the different types of medical imaging scans that can be performed in terms of things like X-rays or CT scans, MRIs, PET scans, and which ones have risk of using contrast agents or radioactive tracers, even radiation exposure itself, that may be at a high enough level to be a potential concern? And how much radiation exposure is there with these various medical procedures?
Now, Scott, for the sake of this presentation, I'm going to be relatively brief with this, but I'll also describe my history with some of these things. So even before the subject of gadolinium and the risk of gadolinium, what I had written about and also caused alarm and anger in the radiology community is that CT uses ionizing radiation, and ionizing radiation can result in cancer. So That was known and published in the New England Journal since at least 1930 and 1940. So this was not remarkably new information. But what to me was sort of remarkable at the time is people said, well, yes, that was true about old X-rays and all old studies and so on, but it's not true of CT. And I said, well, wait a minute. Why is it different for CT? CT uses medical radiation. So I think our earliest works were around 2000. So already at that time, I developed enemies in radiology because many people were angry about, but after that time, many other authors had described in studies that CT uses X-rays. X-rays are ionizing radiation, and that has the risk of causing cancer. Now, while we're on the subject of CT, I would like to keep on with that. So I think that people have to understand, and with all of these things that I'm discussing, unfortunately, you have to understand that there are risks and benefits to everything. The problem is, at this point in time, many of these you have to research yourself, and you are the steward of your own healthcare, unfortunately, but that's the way it is right now. So there is a risk of radiation with CT. Now, it's interesting, since our earliest work, what happened fairly quickly is that CT manufacturers started reducing the amount of X-rays that were used in CT by a number of different fashions. So in the early days, around 2000, I'm an abdominal imager. A CT of the abdomen and pelvis resulted in, and you'll just have to take these numbers, 10 millisieverts of radiation, which, if you look at the large studies, now there is a huge body of research on ionizing radiation and risks of cancer, which really, much of it stems from the original horrific events in Hiroshima and Nagasaki. And research has actually studied how far individuals were from the blast center in determining their risks of cancer. I mean, it's remarkable the extent of research that was done. The bottom line for this presentation is that at that time, 2000, a body CT uses 10 millisieverts of radiation. The studies that have been published on this, and I would draw your audience's attention to the BEAR-7 report, and that's biological effects of ionizing radiation, BEAR-7, where they detail the numbers, not only for adults, but for children. So the numbers, and this is again, Scott, for a 40-year-old male, and that's different for a child. But the numbers for a 40-year-old male is 10 millisieverts of radiation has a risk of 1 in 1,000 of developing cancer. Okay, so uncommon, but if you're thinking that there is 30 million CTs done annually in the US, it's about 28,000 cancers. Now, one of the things about the cancers with CT, and I think important to know, is the bloodline cancers like leukemia occur fairly quickly after the radiation, but that is still not that quickly. So they tend to develop about 2 years afterwards, whereas solid tumors like breast cancer, stomach cancer, liver cancer, and so on takes about 10 to 20 years. And the cancers to date, and I don't necessarily believe it entirely because I think more research could be done on it, don't necessarily differentiate radiation-induced cancers from naturally occurring cancers. But I think there's probably differences in the extent of double-stranded DNA breaks. And that's the thing that radiation causes, double-stranded DNA breaks. And it's DNA breaks that most of the time our immune system can very quickly either kill the cells or repair the break. But in patients who develop cancer, those events don't occur, and these double-stranded DNA breaks result in neoplastic cancer lines of development. So leukemias, around 2 years, solid cancers anywhere from 10 to 20 years. One of the problems with that then, Scott, as you can see, is if it's 20 years later, well, how do you know that it's cancer from radiation or not just a spontaneously occurring cancer? So that to me is a bit of a troubling spot. So that's the thing with the actual modality, the risk of cancer, okay? The next thing is the use of the contrast agent. So iodine contrast for, I will say, 40 years has been recognized to cause renal failure. Now, the most recent versions, which are about 20 years in age, and they're termed low osmolar iodine contrast, their risk of causing renal failure is much less, but not non-existent. And what I like to tell patients, and this is why, Scott, that your podcast, I'm hoping people will learn to identify them for themselves what the risks are because they're not widely known. The people at greatest risk are elderly patients who are chugging along with what would be called mild chronic renal failure, which using effective glomerular filtration rate, that's in the range of 30 to 60. So the thing is that everybody who gets an iodine contrast gets some, at least transient, renal dysfunction. The vast majority of us, it resolves itself within minutes to hours, okay? But if you have already kidneys that are not working well, and most of these people are elderly, and you have an eGFR of 30 to 60, which means you're basically okay. But if you then get that bump of decreased renal function, and you're now shifted into requiring dialysis, that mortality is 40% per year. So it is not inconsequential. The other group to be concerned about are people who have major trauma or some other major systemic illness, like a major infection that has made them very sick. They are, to begin with, fragile. If you take people whose kidney function is already fragile because of these serious events, and then you cause that bump in decrease of renal function, you can cause them to go into significant renal failure and hence a not inconsequential possibility of death. So, and the other thing with iodine contrast is that it causes acute hypersensitivity reaction. Current literature suggests 1 in 150,000 people will die from anaphylactoid acute hypersensitivity reaction. And we'll cycle back to MR in a minute. MRI, the numbers for that is about 1 in 300,000. People say, well, it's safer. And at the time, this is now going back to 2000, 2009, I think, well, yeah, it's safer. But I think it's safer by virtue of the fact that we use about 1/10 of the amount of contrast. And then we'll just look at the famous quotation from Paracelsus that the dose makes the poison. So the larger the dose, the more likely it's a poison. So the safety of MR is really in that arena is that we use a much smaller dose. So typically with most MR contrast agents, we use maybe in the range of 10 to 18 mLs of contrast for a person. For iodine contrast, it's usually in the range of 75 mLs to 150 mLs. So we're basically a factor of 10 different. And that is the safety aspect of it. So those are the three things to think about with CT. The risk of radiation, the risk of renal failure with iodine contrast, and the risk of acute hypersensitivity reaction with iodine contrast. Let's now move to ultrasound. Now, ultrasound is fundamentally the safest of all the imaging modalities that we use. And that's why, to be quite frank, I'm very pleased that ultrasound remains the diagnostic tool for children that's used in most places throughout the US as the go-to initial imaging. And that's as it should be. It's the safest approach, which I didn't touch on with CT and radiation. I told you that a 40-year-old male had a 1 in 1,000 chance of cancer with 10 millisieverts. A 1-year-old girl has a chance of about 1 in 100 of developing cancer from radiation. So many people who know something about medical radiation, and these would be radiologists, would say, well, it's 10 millisieverts and 1 in 1,000 chance of cancer. But you have to know the age. The age is very important. So that's why I'm so happy about ultrasound being used for most things in children. The other thing I wanted to cycle back with you on Scott, is that since my original paper, and it was a year later, the American College of Radiology came out with the identical paper. They didn't cite me, but that's okay. But the point is that after that, the CT manufacturers reduced the dose, especially for children. So the doses are much lower and they're much safer for children. So I don't want to be an alarmist here, but I want people to know that there are risks, but I also want them to know when there have been advances made. So there have been advances made in the amount of radiation people get, especially children. And there also have been advances made in the amount of iodine contrast given. We now routinely give 75 mLs, and 10 years ago, our routine would be 150 mLs. So much has been done with CT and the risks associated with CT. Now, ultrasound is very safe, as it is maybe with everything. Of course, then they introduced a contrast agent, which is microbubbles of air to look at flow in things like liver tumors and so on. Now, the problem is, as I'm sure that you know, Scott, from all the work that you do in medicine, putting air in the vessels is generally not a good idea, because you can get a stroke or a heart attack. So I'm always amazed, safest modality, now suddenly you want to make it dangerous. So I personally, that makes me very nervous, okay? The data suggests, but as you also know from medicine, that the data depends on who you hear it from, right? And it's not necessarily the true data, but it's the data that the group who is informing you leaves the data to be. So I personally am worried about microbubbles. Just the idea of getting air, it doesn't sound good, right? Now, in my earlier works with looking at safety of everything, so I could find, in addition to myself, other people who can talk about safety in MR and do MR. I also could find people who do CT and can talk about the safety issues of CT. Now, this is, Scott, what I tell you, to me, is the black box that scares me. And that is nuclear medicine and radio tracers. Because within the last year or two, there are new radio tracers coming out that are very excited about radio tracers for lung cancer, for prostate cancer. And if you look up online on these radio tracers and you look at sites like Cleveland Clinic and Mayo Clinic and others, what is the radiation exposure? It doesn't say. You can't find it. So one of the next ventures that I plan to do is actually get out the radiation exposure in these tracers, because the standard radiation tracer that's used with PET-CT is FDG PET. FDG PET-CT traditionally, and now I think they've probably tweaked it better, would have a radiation dose of 25 millisieverts. So as you calculate, hey, that's over 1,000, that's more likely than 1 in 1,000 getting cancer. And when do they use it? They use it in patients who have cancer. And you think to yourself, and this is what I think to myself, hey, this person has already shown you that they can develop cancer. So you're going to give them something else that causes cancer. That sounds crazy to me, right? It does. If you are knowledgeable about it, and even just hearing it, you realize this sounds crazy to me. So this is my opinion on that, is that yes, it is effective, and it's effective in a number of settings, in a number of malignancies, not all of them either, but it is effective in a number of malignancies. But rather than getting them every 3 months, maybe you should be getting them every year, every 2 years, and intersperse them with other modalities that are less risky for causing harm, and just space them out more. That hasn't been done. I mean, if I was in charge of radiology worldwide, that's one of the things that I would do right away. I'd say, hey, tell us what the radiation doses of these new traces are. Don't just tell us, hey, this is great. We can see lung cancer with this. Well, what is the dose? I'm worried that the doses, because looking at historical data from nuclear medicine, which again is sort of buried in the sands of time, some of these traditional nuclear medicine studies we talked about CT, standard old school CT, 10 millisieverts. Some of these studies, like with gallium, were in the range of 50 millisieverts per study. So that's 5 times worse. So again, I don't want to scare your audience, but I do want to tell them the truth. And at some level, they have to be the steward of their own health and say, hey, do I need this PET CT for 3 months? Could you maybe space it out with an MR? And I'm nervous about MR and contrast. Could it be a non-contrast MR? Could they occasionally be for small lung nodules? I know CT is so great for that. Could it be a low dose CT? The point is that it should be thought out. And the reality is, I've been in that situation as a director of MR services, and it's no different anywhere in the world. And like it or not, it's the way life is that we want throughput. CT and MR are generally, for most healthcare centers, the largest profit centers. So we want to get people through the system. So we don't want to have, people saying, well, what about this and what about that? Every 15 minutes, we want to get them through, so we're generating profit. And that's why I think that people will have to listen to podcasts like this. Listen, well, Dr. Semelka has told us some concerning things. He didn't tell us the data on the latest lung scans with new novel PET agents or prostate. I want to know about it. And before I get this study, I want to phone the imaging center or the referring physician and say, well, what is the dose of radiation I'm not getting? And the other thing that's very important to point out, and I get this email maybe 10 times a day. Certainly, I get it 5 times a day from people saying, well, I didn't really want to get, and we're going to go back now to MR and gallium. I didn't really want to get the MR contrast, but the doctor told me that I didn't get contrast, then the study would be either worthless or they wouldn't do it. So I tell people, if you don't want to have contrast, don't get it. And if they're not going to do the MR study, you can go somewhere else. And I told them also, there are newer sequences out there that are pretty good. Now, I still use MR with gadolinium. I'm a believer in that. We'll get into who are at most risk. So for many people, it's actually quite safe. But there are people at risk for it, and they should know when they're at risk for it. So the point is that I say, if you don't want the study, don't get the study. There's always options. There's nothing that's 100% the perfect thing. There's other things that also work quite well, but you also have to understand the risks of the other thing. And that's what you need, someone like myself, I guess, to look at the full picture. So if we circle back to MR at standard high field strengths, which are 1.5 and 3 Tesla, I think is safe. The modality is fundamentally safe. But wouldn't you know it, that they do imaging now at 7 Tesla, particularly for the brain, and when people go into the room, they get dizzy because of the very powerful magnetic field and very powerful switching of the gradients when they're imaging. And I'm thinking, well, and this gets back to health in general. If something is telling you this can't be good, probably it's right. If your body is telling you, hey, this could be a problem. Maybe you should be listening to your body. And I think that's, I suspect, a message that you have throughout all of the work that you do in healthcare. Listen to what your body's telling you. So I personally am very nervous on very high field strength. I think 1.5 and 3 is fine. And then with gadolinium, we have the acute hypersensitivity reaction, which is like CT, but safer, I think, by virtue of the volume. And then the new thing that I brought up, which is gadolinium deposition disease. And, when people doubt that it exists, most of the people don't really know anything about it, even if they're radiologists. And I like to think of them as that these are people with an opinion confounded by knowledge. They're saying stuff that they don't know anything about,
Yeah, I had probably 20 years ago a SPECT scan when I was dealing myself with chronic Lyme disease and a bunch of other health challenges. And I remember the contrast agent that they use, they come in a silver locked box and very protected. And I thought, this probably isn't the best thing to be putting into my body. Let's talk a little bit more then about gadolinium. First, is it a metal? And then second, is it also a radioactive tracer? I've read online that it is. I've read that it isn't. And then why do we continue to use it knowing that there are potential risks? Are there not alternatives with fewer potential risks?
So gadolinium is a heavy metal, but as used in MR, it's not in a radioactive form. So it's not a radioactive metal, it's just a heavy metal. And it has relatively unique properties of being paramagnetic, which is within a magnetic field behaving like iron, which for the purposes of MR is very useful. It allows us to see our imaging much better. We have something that acts like iron, which means on our one set of images, which I'm just going to have to say it, our T1 weighted images, it causes relaxation very quickly, which makes it very bright. And our other set of images that we generally use are T2 images, and it makes it very dark. So we generally use it for making it very bright. So one of the things that I always find somewhat mysterious and almost a miracle of gadolinium and MR is that unlike with CT and iodine, when you see iodine in the CT image, you're actually seeing the iodine itself, its effect on the X-rays. With MR, gadolinium, you're not seeing gadolinium. What you're seeing is the effect of gadolinium on surrounding water molecules. And that's what creates an image that looks, in many respects, virtually identical to CT. It causes tissue brightening. And the great thing about that is that many tumors are more vascular than background tissue, so they show up as very bright with gadolinium. Vessels filled with gadolinium show up as very bright, and then we can better see things like narrowings, stenosis, or dissections in the vessels. And inflammation also looks very bright. And all of these things are done with a much greater sensitivity than iodine on CT can accomplish. So we can see these things better. So it's difficult to move away from that, but altogether. Now, are there alternatives? Well, there are other metals that have been looked at, and now we're looking at them again. They didn't work out quite as well as gadolinium in the past. Manganese has been used as a contrast agent, and iron has been used as a contrast agent. But I think now that people are looking again at those metals. Now, the other thing is that they looked at other metals like dysprosium. And I'm thinking to myself, well, if there are risks from gadolinium, why wouldn't there be equal or potentially even greater risks with dysprosium? So I would think, if we're going to use another optional agent, to use agents that are more native to the body, like manganese and iron, and see about tweaking them up. Now, in the meantime, as I touched on, there are sequences that are better able to see tissues in the past without contrast. One large group of them is diffusion-weighted imaging. Another group that we can use on newer systems, the quality of imaging without contrast, of looking at vessels, has gotten better. But still, at some point, gadolinium is a little bit better. And this is why, in my opinion, how things have to be looked at, how you as a patient have to look at things. If you don't want to have gadolinium, in many respects, it depends on what you have and what the risks of are it being hypervascular, where MR with gadolinium will be much better. But for most people, just for time's sake, we just want to get them through and we don't want to hear anything. But, what is the likelihood that I have hepatocellular carcinoma, which is better seen with gadolinium? What is that likelihood? If it's 1 in 100,000, then I don't want to take, for gadolinium, it's a 1 in 10,000 risk of getting, for all comers, getting gadolinium deposition disease. I don't want to take a 1 in 10,000 risk for something that I'm only going to have maybe 1 in 100,000 or 1 in a million. So it seems to me that physicians aren't generally equipped for this kind of discussion. And maybe in the future, we'll see it being better able to have this discussion with AI. But it's at this point in time, patients have to advocate for themselves. And it's interesting, a number of the gadolinium toxic patients that I deal with, they know vastly more about gadolinium than basically any other radiologist except myself and a few of my closer coworkers. And the sad reality is that at this point of time, you have to be asking these questions. I mean, what is my risk? So gadolinium with MR, if somebody had a high likelihood of a small pancreatic cancer, say, well, maybe we can look at you without contrast. And it depends. If there's something that I'm not concerned about, maybe we have to bring you back in 3 months and do it with contrast. Or with hepatocellular carcinoma, if I have a very high risk, I have hepatitis C, or if I have inflammatory fatty liver disease, which now is called MASH, and I have a high risk, maybe I do need to have gadolinium. But can you tell me what my risk is as an individual from being toxic from gadolinium?
Yeah, so you differentiated the acute hypersensitivity to gadolinium from the longer term, almost more chronic illness that we refer to as gadolinium deposition disease. So what are some of the symptoms that you see in those people that are dealing with GDD? How soon after an exposure might we have some recognition that we're moving into that GDD territory? And then is it a spectrum? Do we have some people that are mildly impacted where other people are even potentially disabled?
Gadolinium deposition disease can arise immediately after getting gadolinium injection. But I accept it up to a month symptoms developing. And I just want to reference from a moment nephrogenic systemic fibrosis, the disease associated with chronic renal failure, which is more severe, but a different cell line. The original literature was saying that NSF occurs from 2 months to 6 months following getting the gadolinium injection in people on renal dialysis. Well, with more experience, it turns out it can arise within days and can arise up to 8-10 years later. So with that in mind, present time, since it's a novel disease, and I don't want to scare people too much and make too many people upset, I use the criteria. It can arise immediately following contrast, and up to 1 month, new symptoms can develop, and that all fits with GDD. Now, I just want to take a moment to say what I find remarkable of people who dispute that exists. If you were to ask an 8-year-old child, You got something new you never had before, and immediately afterwards you were sick from it. What do you think happened? Was it something like lupus that developed, or rheumatoid arthritis? Or do you think it was what you just got that made you sick? And this is what I find so remarkable. If somebody just got gadolinium and immediately they're sick, what in God's name else could it be? I mean, it's so crazy to imagine it could be. I mean, to me, it's a level of craziness that's hard to explain, that you think it could be something else other than what you just got. So that's when it can occur. And I would say actually probably the majority, so maybe 75%, occur within 2 days. Well, it has occurred in 2 days. Is this going to be ALS? Is this going to be MS? Or is this going to be a reaction to what you just got, right? I mean, that's just, I like to use the term wisdom sense for the way I think about things, but that's common sense to think, hey, it's probably what you just got, right? So that's the one thing. It just arose relatively recently after you got it. And there are 5 or 6 sort of cardinal symptoms, which I'll mention now. There's maybe another 5 that are also very critical. But then, because it's a systemic disease, it's like any other systemic disease, like atherosclerosis. And we talk about atherosclerosis being maybe the most common cause of death, but we talk about heart attack being the most common cause. Well, that's atherosclerosis. Talk about stroke being maybe the 3rd most common cause. That's also atherosclerosis. But then renal failure from artery disease, that's atherosclerosis. Claudication in the legs, that's atherosclerosis. Impotence in an older male, that's also atherosclerosis. So what I found remarkable in I think it was in 2017, the FDA meeting that they brought together experts to talk about gadolinium toxicity, the experts were thinking, well, how can so many different symptoms occur from one thing? It can't be one thing. And well, hey, wait a minute. Don't you realize the most common disease that exists in humans manifests itself in at least 5 different things, if not many more? So that's the nature of systemic diseases. It's like lupus, something that we well accept. Well, sure, lupus can cause renal failure, but it can cause psychosis. It can affect any system. Any system can be the dominant disease with any of these systemic diseases. So the point is this, is that there are the classic symptoms that are brain fog, burning skin pain, boring, like screwdriver and knife being driven into bones. The classic distinctive for GDD is rib pain. That could be any knee, whatever, any bone can be very painful. Then people have that fasciculation, muscle twitching, and then the pins and needles in their digits and feet that are from small fiber neuropathy, which people think, oh my God, it's small fiber neuropathy, it's from something else. No, that's one of the cardinal features of GDD, is that collection of symptoms. Now, the next group are also very common, which then gets into other major symptoms. So vision problems are very common. Hearing, so ringing in the ears, tinnitus, very common. Many people describe a head pain, and they say a head pain, not a headache, because they say, I've had headaches all my life. And I think one of the best descriptions, but this is different. One of the best descriptions I've heard is it's like you have a swimming cap that's 4 sizes too small, put it on your head. That's what it feels like to me. I've never had that headache like that before. That's why we've called that head pain. But then other major organs, so heart, you get arrhythmias, GI tract, all forms of GI abnormalities. The most troubling for me are stopping of the stomach, gastroparesis, and stopping of the colon and small bowel ileus. And then very common are people experience imbalance, so very unsteady. Now, as a researcher, and I try to tell people, hey, I'm excited about this, but I'm not excited that you have it, but I'm excited because it's such an interesting phenomenon and so interesting to figure out. So, the imbalance is probably not only cerebellar deposition, but it's also peripheral nerves and also muscles. So it's a whole range of things. And then after that, there are 80 other symptoms. But those are the classic, the big 10 or big 11, however many. And those are the most commonly described symptoms.
So if we're considering getting a medical procedure that uses gadolinium, would it not make sense to first look at someone's eGFR, get a sense for what their kidney function is, and use that information as part of the potential risk assessment?
Yeah, I want to talk about risk assessment, Scott. That's one of them. And certainly that's very important for NSF. It's not so important for GDD. I like to know it, but it's not so important. What I want to know is I want to know what other complicating factors exist. So if you look at the sufferers of GDD, the majority of them are white and females. That happens to be the same description for most of the autoimmune diseases. And that's why I group GDD into the category of immune-mediated inflammatory diseases. That's what it is, okay? So white women right there, they go from maybe 1 in 10,000 risk to just those two things, maybe 1 in 8,000. Then you add in complicating factors. And the one that I look for the most, because it's the most common and the most I see associated, are people say, women will say, I am sensitive to everything, sensitive to all kinds of chemicals. What we've come to, and I think now it's partially accepted, is a chemical sensitivity syndrome, multiple chemical sensitivity syndrome. But anything weird. So again, gets back to my Latin quote. If you have something that's thrown off your immune system, you're at risk. So you'll find that many people say they've had Lyme, and some of them don't even know they have Lyme, but then they get tested and they have Lyme. I think the biggest ones right now are going to be COVID and COVID vaccine, and if you look at the symptoms of COVID, and it's interesting that they now describe more and more symptoms till it kind of sounds the same as GDD as far as the symptoms go. And that's why, in many of these conditions, I'm not so sure how much of them are actually now GDD. They may have started with COVID and then gone to prolonged COVID, but then when they get MRs of the brain because, they have these symptoms, neurological symptoms, brain fog, and then they get a little bit worse. And then after the one gadolinium enhanced MR, why is it getting worse? And they get another one. And what I want to stop, Scott, and where I'm hoping this podcast of yours helps, I want people to realize that once you get gadolinium deposition disease, each subsequent gadolinium injection makes it worse. And, it breaks my heart to hear the stories of many of my patients that, as I look at their history, maybe they had something before. Maybe they had like COVID, but then there was one MR with gadolinium and a little bit weird feeling, but, is this now COVID advancing and prolonged COVID? Get another MR with gadolinium, another little bit worse. I have a number of people who've had at least 10, some who've had up to 50, and I'm convinced that it was maybe GDD beginning with the second gadolinium injection. So I want people to be thinking, hey, could this be gadolinium? And unfortunately, at this point, my expectation, and it's happening quite a bit, is patients, most of the time, the patients who come to me, they're the ones who have made the diagnosis on themselves. It hasn't been major centers. It's them that, it seems that I got sick after gadolinium. I'm going to look up gadolinium online. And they eventually find me. And I tell them, yeah, I think it's gadolinium deposition disease. But I think that what's very important to understand with this whole concept of gadolinium deposition disease is that it's kind of easy to diagnose. And most of the people I say, read my blogs. You have these symptoms that we talked about, and it happened within minutes to a month, you have GDD. But I'm now focused on their response to chelation.
So if we are somebody that has an autoimmune condition, maybe a chronic inflammatory response syndrome or mold illness, maybe chronic fatigue syndrome, maybe fibromyalgia, chronic Lyme, chronic viruses, then those are people that potentially have a higher risk, essentially that we already have an immune priming of sorts. And back to your earlier statement, one hell calls for another.
Right.
So if we have one of these other conditions, let's say because of my listeners that it's someone dealing with mold illness or Lyme disease or long COVID, and we're also dealing with gadolinium deposition disease, is there an order of operations in how you would approach treatment? Do we want to fix the immune priming event first, or do we want to address the gadolinium issue first?
Well, no, that's a great point. And the problem is this, that most of these priming things, and you named a bunch of them, there is no curative treatment. Now, some of them, the treatment can be very helpful. So a number of things I think maybe concurrently to do things. For instance, if you bona fide had Lyme now and not some sort of weird chronic Lyme, that maybe gadolinium unleashed, gadolinium deposition disease unleashed it, that maybe we can concurrently treat the Lyme with doxycycline or something similar, and treat gadolinium with chelation. But my view is I don't want to wait with chelation because I know that we can treat the gadolinium. And interestingly, a number of the other conditions respond to how we do it, because we do a combination of removing the metal, but in addition, removing many other metals, including lead. And we use steroids and antihistamines, which as you know, are sort of the conventional treatments for autoimmune diseases anyways, and they've used it in COVID. So a lot of our treatments, in many respects, also have benefit to these other conditions. Because one of the things, for instance, with many things like mold and fungi, is that they love a metal-rich environment to thrive in. Well, if we pull out the gadolinium, and our approach is actually, and it's not recognized yet, although we're working on that, it's the best way to remove lead. We can get gadolinium and lead optimally out. It's the best approach for both of those, a DTPA chelation with methylprednisolone and an antihistamine. But other metals also respond. But the whole subject of heavy metals is now, for me, a new area of expansion into. But I believe that the things that you need to do are the three things for all diseases are avoidance. Then you want to have detoxification. And if you can, removal. Well, what's nice about gadolinium is one of the few of the entities that you mentioned that you actually can remove the offending agent. We can remove gadolinium and we remove lead extremely well with IV DTPA chelation. Avoidance is obvious too with gadolinium, not obvious with lead or other things. But I tell people, if you think that you have been sick from gadolinium, never get another gadolinium injection again. That accomplishes, and even just doing that would, I think, remove 75% of the cases that need to be treated, but would remove virtually 100% of the cases that I don't like treating because they've had so many gadolinium injections. It then becomes like you went from a small renal cancer that we could cut out to now renal cancer where there's metastases everywhere. Certainly we can help you, but the amount of chelations may be so numerous that almost no one can afford it.
I wanted to just dig in a little bit more deeply into the comment you made or the connection you made between mold, fungi, and gadolinium. And I know my primary mentor, Dr. Dietrich Klinghardt, he's talked for years about how sometimes fungi in the body can actually be protective in protecting us from heavy metals. And thus, if we're not addressing the metals and we come in with some antifungals, potentially we're releasing or redistributing some heavy metals. I'm wondering, does that also potentially happen with gadolinium or not necessarily?
Well, what I found interesting is now, starting off with gadolinium, then I had to branch into heavy metals and then next thing, branching into everything else in healthcare because people may start off with some other unusual entity. And I think the point that you make is very important, is that everything exists in a balance. And there actually has to be some of the players that are potentially bad players have also to be present, but in a manageable amount, because then they serve as a way for your immune system to stay healthy. So you do need, we don't want to eliminate, as all bacteria, we need, and we've identified, the best bacteria, microbiome, but still we want to have some of the bad players as well, but in small numbers. But fungi of all kinds are critical for us to exist. I even have to extend it to wonder, maybe some of these parasites that we have, maybe some of them are also helpful to keep the immune system, active. And the whole thing is, what I'd like to use is the concept of a Goldilocks principle. Things have to be in the right balance. So it also makes me very nervous when people will think, well, if you're saying, Dr. Semelka, that the big problem is inflammation, maybe I want to be completely antioxidantized and anti-inflammatorized. But the problem is that then you are susceptible to cancers and major infections. So you need to be right in that balance. Now, I think what's happened to us in the modern age, and I see it almost like those, level lines that you have for, when things are at level. I think maybe 100 years ago, we were at level that the correct balance between antioxidation and oxidation was right here. But now we're shifted that we have to be a little bit more, but not too much more towards antioxidant. So that's why I think that we all should be on more or less some kind of an antioxidant diet. That will benefit everything, and certainly benefits, gadolinium deposition disease. But our shift is a little bit, but the point is it's a little bit. I don't know how much is the exact perfect number, but if you shift too much, now you're at risk for TB, serious infection. If you're too antioxidized, because oxidation is what kills cancer cells and serious infections. So you have to be careful and be in a balance.
I am loving your comments. This is so much fun. I totally agree with you that parasites may play an immune modulating role. We see the use of parasites as therapeutic tools in some conditions like PANS and PANDAS in children. So not always a bad thing. So thank you for those comments. Let's talk a little bit about testing. How do we explore the potential for gadolinium toxicity? I know there's labs that have urine tests and stool tests and hair tests and blood tests or serum tests. I know biopsies can be used. So what do you find most helpful? I remember years ago in the autism conversation, Dr. Klinghardt would say, if you looked at two children on the autism spectrum, looked at the hair metals, the child that likely would recover was the one with the highest level because they were excreting the metals rather than the child that potentially is retaining them. So do we need to think about that potential as well when we're evaluating some of these labs? What if someone isn't a good detoxifier and maybe they're more of a retention type person or a bioaccumulation person where the gadolinium is stored in tissues and not being excreted? Could we potentially test that kind of person and have a false negative result because they're not able to excrete gadolinium?
That's a very important question. I'll tell you how we handle it. And I am certain, like with everything, I think we probably do a relatively superficial approach. It's probably more detailed, but from my point of view, it's awfully good and better than anything else that currently is happening. So what we do is this, and it works for a number of, actually, the principles are the same for all heavy metals. And what I want to sort of talk to you about, first I'll talk about the testing, and then I'll talk about what we look for to tell us that what they have is either gadolinium deposition disease or lead toxicity, which you could also call lead deposition disease. So I like 24-hour urine tests for heavy metals performed a day or two before doing chelation. Then if it's gadolinium or lead, the optimal chelating agent is calcium DTPA. So we give that as an intravenous injection relatively rapidly, but as 2 split doses and with steroids in between. If you want more expansion, we can talk about that later. And then about an hour after chelation, which is timed so that they've had a first urination after the chelation's been in, because most of the urine at that time would be from prior to chelation. So we standardize, and I think with everything, standardization is important. So as soon as they have the first urination after they get chelation, we ask them to collect for another 24 hours. So we see what the baseline is, and then we see what post-chelation results in. And just to go over those numbers, just as examples, what classically we'll see from somebody who has gadolinium deposition disease for, we'll say, a year, that their baseline gadolinium will be very low. So many doctors, if the patients say, I'm sick and I think it's gadolinium, they'll do a non-provoked, I call it a native urine test. Gadolinium. Gadolinium will be low. It'll be in the normal range. They say, well, you can't have gadolinium deposition disease because the gadolinium is in the normal range. The point is, by 1 year time, all of the gadolinium is more or less fixed in tissues. And the 2 largest repositories are bone and skin, but it goes everywhere else. And that's why any symptom can, so it's going into brain. That's what everybody talks about, but the brain is at best the 3rd largest repository. Bone and skin are the largest ones. So most of the gadolinium is fixed in the tissues. So the unprovoked urine will be, gadolinium will look normal and say, you can't have gadolinium is normal. So with the chelation, that's why it's important to time it, because probably the most gadolinium is being removed from 1 hour to 3 hours post-chelation, but we acquire the full 24 hours. So typically what I would see is for 24-hour urine at 1 year's time, 0.5 micrograms per 24 hours pre, which is in the normal range, and post, depending on the agent. So most of the agents that we would see, which I'd say maybe, Gadovist, Multihance, and Magnivist would be the most common we would generally see. The gadolinium will go up anywhere from 20 to 50 times. So people would say, well, geez, then, they're clearly sick from gadolinium. Lead would also do the same. So lead, we see, goes up also about 20 times. And by the way, everybody has lead in them, maybe everywhere in the world. All of us have lead in us. And I think they also interact with each other also as an extension. But what we need to observe, and this is a thing that I want people who do chelation, because I'm not sure how many people understand who've been doing chelation even for many years, these critical components. You're looking at gadolinium removal, which occurs right away for 3 days, and the reaction to it, because if you're sick from gadolinium, when you bring it back into the circulation, it's going to make you sick again. So you get gadolinium removal flare. If you've used a poorer chelator, like EDTA or DMSA, you'll also get gadolinium redistribution flare, which is it's picking up the gadolinium, but it's then re-releasing again, and some of it's going to go to the brain. So that redistribution is never good. You never want redistribution. But for the majority of people, and this is what is so critical, and I think almost nobody understands, and it's true for all heavy metals, that the largest repository is quite often the most stable, holds on to the metal the longest. So for both gadolinium and lead, the largest repository is bone. So DTPA can directly remove some gadolinium and some lead from bone, but how to get rid of it is through the principle called Le Chatelier's principle, that everything strives to be in equilibrium. So when we give powerful chelators, it removes a lot of gadolinium from skin, brain, liver, kidneys, tiny amount from bone. At around 3 weeks' time, the body re-equilibrates the gadolinium pools of gadolinium. So gadolinium then moves from bone. Some of it will move through the kidneys and out. The kidneys are working well, but will remove back to skin and back to the brain. What happens then at 3 weeks' time is that they start getting the symptoms back. And then they're, oh my God, it didn't work. I'm feeling just like I did before. But I tell them, hey, this is how it works to get all the gadolinium out of your body. Because many people focus on getting the metal out and it's one and done. Lead, I've given one chelation, got all this lead out, we're fine. No, lead goes to bone. You need to cycle through at least 3 to 5 re-equilibration phases, where at 3 weeks' time, gadolinium is moving back to skin and back to your brain. So burning skin pain's coming back, circulations are coming back, the brain fog is coming back. Don't panic. That's normal. We want to see that because we can get the gadolinium out from your skin and your brain and the lead out from that, but we're not getting a lot out of bone. To get your total body heavy metal down, we need you to re-equilibrate it out of bone back to where we can get it out of the soft tissues. So a number of people are very perturbed that they've done 5 DTP chelations, and every time their urine post-chelation is 24 micrograms per 24 hour, which is in the red range. And they say nothing has happened. It's still in the same range. I tell them, listen, actually good things have happened. It means that we're getting the gadolinium out, because that's what the 24 micrograms for 24 hours is. And the reason why it's still 24 hours per micrograms after 5 chelations is that gadolinium is moving from bone back to skin, where we're getting it out from, skin and brain. So we want to see that. That's a good thing. When we know that we're now reducing your total body content of the heavy metal is when it starts dropping. So when the post-chelation drops from 24 down to 10 micrograms, that's telling me now we're getting rid of the gadolinium out of bone. Now we're truly reducing your total body content. Because I think that's the thing many people don't understand. We want to reduce the total body content, and this is a measure of doing that. So I tell people, well, these are the things that I look for. I look for at 3 weeks out, maybe you're getting a little bit of the symptoms coming back, but it's not bad. Let's see, if it stays not bad, let's see if your body can recover the rest of the way on its own. But don't panic if at 2 months you're starting to get really sick again. It's not like anything's been lost or wasted. It just means that you have the combination of a lot of gadolinium still moving from bone back to skin, and you also have a heightened immune reaction to the presence of gadolinium. We just will keep chelation. So I look for the gadolinium to go down to about 3 to 5 micrograms for 24 hours, which is low yellow range on doctor's data and other testing, and for your symptoms to not re-equilibrate so much at 3 weeks' time. It's something that I can manage,
And when you have this re-equilibration symptom picture because there is some movement within the body, is that symptom picture usually better tolerated than what occurs when you use a poorer chelator with a poorer stability constant and leads to a redistribution of gadolinium? How do those compare in terms of the severity of the symptoms?
Well, I would say that redistribution is never good to begin with. But the symptoms in general, in many respects, it depends on how much gadolinium injections you've had. So I tell people, once you're on the chelation train, especially if you've had a bunch of gadolinium injections, you have to stay on it, because the re-equilibration symptoms can be even worse than the symptoms you had to begin with. And this is the explanation, that when you first get the gadolinium injection, the antigen presenter cells, the dendrocytes, show in lymph nodes the T cells, the gadolinium. So, well, what do you think of this? Now, in people like myself, and I've had 15 injections starting in 1989, so be amongst the first in the US to get gadolinium, but I don't have any symptoms of GDD. So the dendritic cells show the T cells, and in normals, which are the vast majority of people who don't react, I call these people gadolinium storage condition, because we all store a gadolinium, shows a T cell. And what's interesting is everyone reacts with cytokines, everyone who has gadolinium. So, and we tested cytokines, and that's actually a very interesting topic. But everybody's responding. But the difference is that the majority, which includes me, most of the cytokines that we release in the presence of gadolinium are calming cytokines, so suppressor cytokines, basically cytokines that are saying to all the tissues in the body, calm down, don't react to it. Whereas people who have GDD, even if the total amount of cytokines is much lower, which most of them are lower than mine because I have so much gadolinium in me, but most of their cytokines are activator cytokines, are helper cytokines that promote inflammation, so also called pro-inflammatory cytokines. And this, if I was to think, if I had a lot of money, what I would want to do is continue the research we did in preliminary phases looking at cytokines, because it will not only answer gadolinium and heavy metal, but I think it'll also answer questions about vaccines, because it's such a fascinating subject.
You talked about doing pre and post provocation metal testing in the urine. Would you expect to always see zero if someone had never had gadolinium contrast, or are there other sources in the environment, in the world, where someone could have exposure to gadolinium, and could that be enough to trigger a very sensitive person to have GDD?
Well, there are some things that I hesitate to get too much into, not to cause too much fear. But one of the things that we do know, with so many gadolinium-enhanced MR studies being done in major cities, we know that the water supply in many of these cities is very high in gadolinium. And to date, I sort of discount that gadolinium consumed orally through water supply can cause GDD. But I'm not saying that because I'm certain of it. I'm saying that to avoid panic, and I have no evidence yet to say that it does. But would I be surprised if it did cause GDD in some people? No, I wouldn't be. So, and I would like to extend from this point, is that a number of people have used zeolite. And when you talk about testing, so the only testing I do is 24-hour urines pre and post, with very tight pre, just before, post, 1 hour after the start. So it's standardized. So I know exactly what's happening, and I can compare and that individual to themselves over time. I can compare that individual to other individuals. So standardization in everything is important. But zeolite is healthy for many people who are restoring their microbiome, which I think is one of the first steps, maybe for all of us, is restoring the microbiome and getting to detoxification, also useful for gadolinium. But zeolites, it turns out, contains gadolinium in it. So I had to sort of react to, some of the patients early on who were saying to me, well, zeolite is working because doing stool samples prior to zeolite, no gadolinium, post zeolite, gadolinium's coming out. So gadolinium, zeolite is pulling gadolinium out. At first I thought, well, I can't really understand that because most of the gadoliniums are excreted just by renal. And unless, the thing I've learned is to be open to new ideas, not sort of closed to something couldn't happen. But I think unless there's a new excretion pathway directly from small bowel or colon, which is possible, but I've never heard about it, I have a difficult time to understand it. It turns out that actually more recently, one of my patients, I'm also looking at what zeolite is composed of. It contains gadolinium. And they tested zeolite and it contains gadolinium. So most recently, I've told people, I wrote a blog maybe 2 months ago saying zeolite is a good thing, maybe try it. I wrote a blog a week ago, GDD patients shouldn't take it because it contains gadolinium. And even though I'm not sure that orally gadolinium can affect, it's just not worth the risk. And to be frank, I'm not 100% sure. And it does make me nervous that there's a lot of gadolinium in the environment.
So talking more about excretion of gadolinium in urine versus stool, the kidneys are far less able to repair than potential damage moving through the digestive system, through the colon, and out in the stool. So are there ways to remove gadolinium from the body where the exit is via the stool rather than through the kidneys and urine that are far more sensitive to potential damage? Or if we're using DTPA, is that always excreting through the urine?
This is also a very important point. Now, a number of the gadolinium agents can have both oral and hepatobiliary, which means coming out through the biliary system, the small intestine, out through the colon. Most of them are pure renal excretion, and that includes also DTPA. DTPA is the ligand of Magnavist, which there's been something like well over 100 million doses of Magnavist given. So in using DTPA, it doesn't make sense to test stool, for instance, because it's going to be coming out through the urine. But HOPO, which is an agent in development, that also is eliminated by the hepatobiliary system. So again, thinking, and in many respects, all of these things in healthcare are like a 3D chess set. And I want individuals to realize you are playing a 3D game of chess. Unfortunately, you have to determine yourself. But hopefully, from sources like this, what we're doing here, you're better equipped to play this game. Now, Multihance and Eovist are also eliminated through the hepatobiliary system. So there will be some of that eliminated in everyone through the stool. HOPO is an agent that has some amount of elimination through the hepatobiliary system. So in time, in the future, now HOPO is available through purchase in China. I can't advocate it, but some people have no option because of money, but I cannot advocate it. But if your kidneys were functioning poorly in the future, or, if you had no option now, HOPO will also eliminate gadolinium through the stool. Now, although I'm an abdominal imager, I've never been so crazy about stool. So I tell patients, well, if we're going to measure stool, maybe I'll give you all the testing kits. Maybe you'll do that yourself. But my clinic does test all the urine studies right now. But if you're not using HOPO, there may be not a good reason to test stool. The other problem with the stool is that one of the things that, as I mentioned early on, one of the symptoms that patients suffer from is constipation. So at what rate is it going to be coming out if the patient is very constipated? You may have elimination, but it's not registering because your colon is all bunged up. So even with HOPO, for instance, I may still, for the majority, want to use kidney. But I think the point is valid. What about patients with very poor renal function? And to be honest, that's something, DTP chelation and dialysis, something that I've thought about.
Are the symptoms of gadolinium exposure entirely toxigenic, or can they also be immunogenic? With some other metals, for example, I know there's the concept of a type 4 delayed hypersensitivity reaction. We can, for some metals, do a ELISA test that was created by Vera Stechkel. And so I don't believe there is a ELISA test available for gadolinium, but wondering how much of the symptom presentation of gadolinium deposition disease is toxigenic versus immunogenic. It sounds like it may actually be both. And then are there any tests we can do to test for biocompatibility to gadolinium before we even have that as a contrast agent?
Well, that's excellent. I find the concept of immunogenicity and toxigenicity is very interesting. And I like to also think of it in terms, because it's something actually, even within years for me, is relatively new to be considering this. Because I like to think, for instance, of the viral pandemics. And if we think of the viral pandemic, the flu of 1918, many of the people who died were young adults, relative sparing, young and the elderly. In the setting where young, healthy people die, it tells me the primary thing that's happening is your immune system is being activated so that it results in a cytokine storm, which is what's killing you. So if young, healthy people are dying, it's because of primarily the immunogenicity. Whereas other entities, if it's the standard viral infection where young and old die, the young, immature immune system, the old because a weak immune system, then much of it is from that it's more toxic. I think that gadolinium deposition disease is kind of in the mid-range. If you look at animal studies done on gadolinium, and those studies kind of show that gadolinium is toxic to everything, basically because gadolinium can insert itself into calcium. Wherever calcium is, gadolinium can insert itself. So it inserts itself in synapses and nerves. It inserts itself in actin myosin for muscles. It inserts itself, nerves again in the heart. So basically, and smooth muscle in the actin myosin relationship. So basically, it can insert itself into everything. So if you read the animal studies, you think, well, Jesus, it's so toxic. But then you take a step back and you think, well, why am I not sick? I've had 15 gadolinium injections. Why are the vast majority not sick? And this is one of the things that I think in many different areas, they're starting to appreciate the relationship between immunogenicity and the toxicity and their relationship. And I think that gadolinium may be almost in that perfect mid-range that you need to have the immune system to allow entry of gadolinium into all these sites, that otherwise in normal people, somehow it's blocked. Is it blocked by cytokines inserting on cell surface receptors? So the point is that this is such an interesting area of research for everything. And I think actually that gadolinium is a very good model to use because we can determine exactly how much gadolinium they received, an individual, and we can also determine exactly time zero of an immune reaction arising from chelation. Because when you chelate, you're remobilizing gadolinium and you're basically creating a mini gadolinium injection. So you can then trace all the cytokines to see, how much of this is then, and where are they going, these cytokines that have allowed all of these bad things to happen and be 1 in 5 or 10,000 people that's not occurring in everybody else. And how can we promote in these people, and by extension, other diseases, that this phenomenon doesn't occur? Is there a drug that we can develop that can support either T suppressor cells and suppressor cytokines from calming things down from cytokines that are pro-inflammatory? I think it's all doable. And getting to the other part of your question is testing. Well, some people have used skin testing, but that's fairly long-term. That's why, for me, the investment I would like to make in research that I've pointed out now for a couple of years, I think right now that gadolinium deposition disease, and probably by extension these other things, NSF, maybe even acute hypersensitivity reaction also, and maybe it's the same gene cluster. And beyond that, why not have this testing for if you're going to react to a COVID vaccine, if you're going to react to the human papillomavirus vaccines, all these different vaccines? I think it's all knowable. You just have to have the will to figure out, hey, these are people that develop these autoimmune reactions to it. Let's study what their cytokines are and compare it to normals, and let's try to promote what the normals are doing and suppress what the people with disease are doing, but also to begin with, see what gene it is. I think that all these people that have horrific reactions to the measles vaccine and so on, there's a gene for that. So companies should be testing for that. I think there's a gene for GDD. I think a person should, and I think there's no reason it can't be developed now. The knowledge and technology is there. It's a matter of wanting to put the money and the interest there. But person comes in, they get a blood sample or they get a buccal sample. They say, you can't get the conventional COVID vaccine. You can get a flu vaccine. You can or can't get gadolinium. You can get iodine contrast. I think there could be a panel that automatically you have a printout of what you can and can't get.
Boy, you're a dreamer, aren't you?
Right. Yes, you're right.
Does gadolinium cross the blood-brain barrier, and could it over time then, I know it has the potential to reduce BDNF or brain-derived neurotrophic factor, could it over time lead to some cognitive challenges, maybe even be a contributor to dementia or Alzheimer's disease if we don't get it out of the body?
Again, that's a scary subject that I have tried to avoid to some extent because I have enough enemies in the radiology and neurology community that I don't want to make all of them
fair
enemies. But I think your point is very valid. And certainly it does cross the blood-brain barrier. But the question, again, that data should be out there because we can see gadolinium on scanning electron micrographs. But I want to know how many of these gadolinium particles are actually getting into neurons. Because right now, I'm thinking that most of the gadolinium that's retained in our bodies are retained in the extracellular space. So the space between, between the cells.
Yep. The interstitium, the extracellular matrix.
Yeah. Am I 100% sure? No, I'm not. But there are people who are doing electron scanning microscopy showing the presence of gadolinium. I would like to know for sure, because otherwise, I think, well, I don't think it's something that will lead to permanent injury in my current sort of hopeful viewpoint if we get it out. And that's also why, for instance, with something like gadolinium, unlike these other metals that may be either consumed or inhaled, we're getting gadolinium right now by intravenous injection. So that's why it makes sense to me, the way we do it, that we are using the DTPA to chase down gadolinium where it is, where the majority is in the extracellular matrix. And that's why I also like to push it as a fairly firm hand-injected push, because everyone who has gadolinium now in their body had it administered at a rate of 2 mLs per second at least. You can say, well, why was it administered so fast? It's because the enhancement is much better of tumors, of normal tissues, so we can see inflammation in tumors better by flooding the extracellular matrix and flooding the capillaries with a lot of gadolinium so we can see lesions better. As a result, the gadolinium, it's like the tire tracks. The gadolinium is left behind by the route that we administered.
Does the DTPA cross the blood-brain barrier to help chelate gadolinium in the brain, or is that something that relies on the re-equilibration scenario that you talked about?
I think it's probably both. There was a study that was published by Bayer some years back looking at a rodent model, and they used it actually to show that their agent Gadovist was safe compared to a linear agent, and they may have used Omniscan. But what they showed, which is where I use that reference, is that they showed that DTPA, and they used DTPA as a chelator, DTPA, they showed removed gadolinium from the brain of mice. So for me, I was happy to see that gadolinium actually does, in an animal model, was actually shown to remove gadolinium from the brain. So it does cross the blood-brain barrier, and it can actually remove gadolinium from the brain. But I'm also sure that probably the re-equilibration helps, quite a lot in the brain as well.
Many of our listeners are dealing with mast cell activation syndrome, dealing with histamine-related issues. I'm wondering what the connection is between gadolinium and it being a potential trigger for the mast cells to release all kinds of pro-inflammatory mediators, histamine, and hundreds or thousands of others. And is there potentially then some value in taking a mast cell stabilizer or antihistamine before the administration of the gadolinium? Do you think gadolinium can be a trigger for mast cell activation syndrome?
Well, I think it goes both ways. I think both can trigger each other. Talking about agents to take, I think most often things end up with GDD being the secondary thing, that they start with mast cell activation. But it also goes the other way as well. Additional medications I've generally have shied, but not entirely from, because many people are sensitive to many other chemicals. And the other thing is that, and when people say, if they're worried about DTPA, what is it doing? It's basically a simple cation exchange equilibrator, which means it's releasing calcium or zinc and picking up another cation. It's not changing dopamine, serotonin levels, nothing else. It's just exchanging cations. So it turns out that heavy metals have a higher stability with DTPA than zinc or calcium, and that's why preferentially these heavy metals are picked up. Now, I happen in many settings to like calcium DTPA as it is a weaker bond than zinc DTPA, so it tends to pick up even more gadolinium, but by extension, it also picks up other native metals. So it's like everything else, and everything else I'm sure that you deal with, Scott, is that I tell people to do this well. Seems easy. It's not that easy. And an analogy I like to use is water polo. When you're watching the Olympics, you look at water polo and you think, well, swimming around in the water, throwing a ball in a net. How difficult is that? Well, it turns out to do anything really well may look on the surface simple. It's very difficult. So many of the points I think that you're now delving into are points that I think are very complicated. I'm cautious myself, but I also am very cautious telling people what else to do. Because, for instance, people say, well, what can I take in addition? And I tell people I would stop supplements 2 days before and not start them again until 3 days after, because I don't know in the supplement how many have cations that DTPA can pick up. And it's not that I'm so much concerned about that it's pulling off a cation of a supplement, but I am as well, and certainly of drugs. I don't know what pulling off a cation is going to do to the drug, but that it's making DTPA less effective because now it has, for instance, some people have used magnesium in the IV solution because they find that people have less flare. And the reason they have less flare is now they're picking up magnesium and not gadolinium. They're picking up more magnesium. So I don't want anything put into, we use normal saline, don't want anything added to it. I only want, if you're on insulin or anything else that's life important, yes, keep taking them through the course of chelation, but I have no idea what cations anything contains, and I don't want them pulled off either to cause a problem with supplement or whatever, but also to reduce what we're doing as far as chelation.
I want to talk a little bit about gadolinium and the nerves. You mentioned one of the symptoms being small fiber neuropathy, which in my realm of understanding in chronic Lyme disease is often treated with IVIG, for example. So I'm wondering if someone has small fiber neuropathy, are there other things then that you might need to do besides the DTPA, or are all of the symptoms reversible once the gadolinium is eliminated from the system?
Well, with something like gadolinium, and I suspect maybe also with lead, we're so effective at removing the causative agent that I don't think anything else is necessary. Now, people who've had 50 gadolinium injections, would we need to supplement in order to have things manageable? Probably. But as a whole, and actually, I'm glad that you brought that up, because a number of people have things like small bowel stasis. In fact, some, they were contemplating small bowel resections, or I've had even a couple of physicians who had ablation of the nerve channels in the heart because of arrhythmias before having chelation. So what I tell people before doing anything major, at least give 5 chelations with DTP a chance, if not 10, to see how much of it is resolved. Because I think the other point that is maybe important to mention at this point is that people may think, well, Dr. Semelka is thinking that DTPA cures everything. And, once you have DTPA, everything's cured. And no. And the other thing to realize is that, there are patients who've died with GDD from things like heart attacks and, gadolinium. And, I have to tell people to stand back a minute. Heart disease is the commonest cause of death. And when people say, that chelation has cured multiple myeloma, then, well, probably not. But I think what's probably happened is that you had a small chain protein response to the gadolinium because your immune system is trying whatever it can to capture gadolinium. So it's doing like the Spider-Man thing and trying to goo it up with protein, which is very common. And I think that's maybe the most active form of gadolinium for toxicity is protein bound. But our body tries to protect the vital organs by shifting the gadolinium to bone and to skin, and also to, throw out protein goo to bind it so it's not going to be more toxic. So a lot of the things that it's achieving are, and even, like the use of antihistamines, which we use routinely, which again would help with mast cell activation syndrome. I think that a lot of the things that we do have benefit to all of these things. And a lot of these things may be in some ways in part due to it. Like I know that some people have been treated with chelation for autism. And I think some physicians actually lost their license for doing that. And I think, well, maybe, it shouldn't be thought of as a cure for autism, but if that autistic person had high lead or gadolinium, high lead probably most likely, this works for it. So if it's framed that way, test for. And one of my current patients with lead toxicity, he can see depression coming and going based on the re-equilibration flare. So I think, for instance, that the role of heavy metals in depression is vastly underappreciated. And it's a simple test. It's not a complicated test. You're not biopsying your brain. We're doing 24-hour urine pre. We're giving DTPA. Maybe in the future, we also would instead, or in addition, give HOPO at another time. We see what metals go up, and we see if you're more symptomatic. That's a simple test.
Does gadolinium have some negative impact on our mitochondria? Can it become a DNA adduct where we may need to also support mitochondrial function? But what are your thoughts on the potential negative impact on our mitochondria, on our ability to produce energy currency?
There are a couple of papers written by authors other than myself that looked at mitochondrial injury and markers for mitochondrial injury. And they described that mitochondrial injury is observed with gadolinium, not only patients with disease, but without disease. So there's no question that it causes mitochondrial injury. But again, Scott, I would get back to the point that if it's something that's known that can be treated, I prefer to start with chelation before then contemplating other things. But there's no question, and this is something, you're bringing on things that I'm now contemplating what's next. And clearly, I'm thinking, well, what's next about that, about mitochondrial injury? Because clearly at some point, some people can be too damaged, either from too much gadolinium or their immune sensitivity is much greater than other people, that they have damage that simply getting the gadolinium out can't cure. And even the other thing that I've had to come to grips with is, what about very rare diseases that cause T cell or some other immune system dysregulation, that now that you've given gadolinium, that gadolinium deposition disease, maybe even now that you're chelating, now you have unleashed a monster, And I think that most things that we have positive effect on with chelation, most other diseases, but there are rare individuals that I think that we've unleashed a monster with gadolinium, and chelation doesn't seem to help that. And now we have to look at the things that you're talking about and looking into more detailed treatment. But that's for my own level of stress. I'd like to try to keep things as simple as possible, as much as I can do.
One of the more commonly overlooked issues in the listeners of this show, in my opinion, is hypercoagulation, that we can have hyperviscous or thick blood from chronic infections, from now COVID. One of the most significant issues in long COVID is hypercoagulation, potentially microclotting, those kinds of things. Wondering, do we know if there's any connection between gadolinium and hypercoagulation or thickening of the blood?
It does occur, but thankfully it's relatively uncommon. But then I also wonder, how much of any of these is the combination of a number of things affecting our immune system. One analogy that I've used in the past is the jugglers, or what you would call them, entertainers, that can spin a whole bunch of plates on top of like poles. And I think, and I'm sure that many of your podcasts have dealt with this, that we all of us are dealing with microplastics, we're dealing with glyphosates in our body, we're dealing with PFAs, we're dealing with other heavy metals. How many spinning plates can our immune system keep up? And I think it varies from person to person. And that's why I think one of the biggest, maybe the biggest healthcare issue that we have as a developing nation is the whole family of immune-mediated inflammatory diseases. I think to a greater or lesser extent, we all have that we never had to have, we never had before, because we're all dealing with, I just named 7 or something like that, but we have to imagine there's at least 15, maybe there's at least 100 different things that we're expecting our immune system to keep all of the plates spinning, and at some point, we can't spin them anymore and they fall down, And that's why we have to be very careful. And I'm sure that's a message you give to all of your viewers, all of your podcasts. You have to be attention. But I also like to say to my patients, you have to be sensible and rational, but you can't also drive yourself crazy with this, because stress itself The cytokines related to stress also follow GDD. So do your best. Don't eat like too highly processed food. Try your best in everything, but don't drive yourself crazy. And I'm sure that's probably a dominant message you give.
I am not personally a huge believer that all of our problems are caused by the MTHFR genetic SNPs or single nucleotide polymorphisms. But I am curious if you see any connection between those people with impaired methylation and a greater potential for the development of GDD. And why do you choose some agents that are already methylated as part of your treatment approach?
Well, I would estimate that probably a third of our patients have some sort of MTHFR variant. So, and I think that, for many diseases, probably we're not looking at a single gene, but a cluster of genes. And I think one of the genes in the cluster, which may not be a dominant one, but in the cluster of GDD, I think is the MTHFR. I think it's a small component. So knowing that when we, insisted on testing that a third of people have this, I just, assumed that everybody could. So we use methylated drugs. We use methylprednisolone and Clarinex, which is a methylated Claritin. So we just use them assuming that people will have a high likelihood of having that.
When you are treating someone with GDD, how important is it to consider supporting channels of elimination, the liver, the kidneys, the lymphatics, the extracellular matrix that we talked about, in order to optimize the body's inherent ability to drain or detoxify? And could doing some work in that realm potentially minimize the redistribution that you talked about as well? I'm very big into using homeopathic drainage products, a lot of the ones that originated in Germany from companies like Pacana or Energetics. I mean, there's a lot of these on the market. In fact, personally, if I'm going to do something that has a radiation exposure, Pacana's Radinex product would be one I would think about. So I'm wondering if you've explored the use of any homeopathic drainage to support your patients.
I don't come into this picture as an integrative medicine specialist. I come into it as a radiologist with very good knowledge of the contrast agents, gadolinium, and knowledge of the concept of chelation and how stable chelations and so on are important. So I'm in the learning phase of this. But what I like to think is that what I've learned maybe with age and maturity is to be more open to things. People tell me stuff. So I encourage people to try different things and to tell me if they work. So I'm very keen on, and I look for a number of people to say, hey, this worked, not just one person. So for instance, I'm very big on turmeric. Is not only, it's been used in many different heavy metals, found to be beneficial. Everybody has, a bunch of different heavy metals. Everyone has lead. Most people have some mercury. So I think, you should be on turmeric. And a number of people have responded well to chlorella, spirulina. I tell them, listen, these are things that I recommend doing. But as a whole, what I've found is that, one of the problems with the supplement market, if you like, is that, as you know, to get anything FDA approved is a minimum of $100 million or $500 million. So most, if not almost all supplements are not FDA approved. We don't have that basis. We have to go by, I like to go by, literature and actual experience of patients who I know have GDD and how they've done. So it's a little bit more convoluted, but I start with, I think, what every person who's interested in healthcare globally, from wherever you start, is that for me, I've realized more and more, start with getting the microbiome in order. I don't know, how many supplements really are helpful to liver or pancreas, but I do know that eating a healthy diet is going to support all of those things. I want you to start with doing those things. those, and that's why also I'm not a great believer to a lot of the IV injections of things, because I'm never convinced that maybe the benefit of those IV injections is that your kidney is eliminating them, and by eliminating them, actually also eliminating other toxins. So not a direct beneficial effect. And that's why I think, if you can restore the microbiome and get a healthy diet, that your body, the vast majority of people, body, and these steps from bacteria to fungi to the cells, there's maybe 5 metabolic steps that are gone through to get various metabolites like glutamine in your body. That has been done by the body. And I'm not sure that injecting it by IV is going to be useful to the body. What I want people to do is start with getting your microbiome in order, that your bacteria are functioning properly to process various chemicals in the form that your body can use, so that the next few enzymatic steps in your body gets in the form that it can use. So I'm very much a believer in all of these things now, which again is sort of a separation from an allopathic physician past. But I think all of these things are very important. And I'm a big believer that small amounts of certain things, so homeopathy is probably very important. And some of the drugs that I have in mind to use with GDD to control things are big-time drugs, but used in homeopathic amounts.
Yeah, my mentor again, Dr. Dietrich Klinghardt, he will probably enjoy that you mentioned chlorella. That's been one of his long-standing heavy metal and other detoxification support tools. Wondering if you've seen any role for glutathione in people that are working on detoxification of gadolinium.
You see, and that's what I'm not sure about. So I don't advise it, because there are people who have taken glutathione and it's not clear that it's helped. And it gets back to my point that if you have a healthy microbiome and a healthy diet, you are creating the glutathione that you need. And I'm not sure that giving it IV, your body doesn't want it that way. It wants to make it in the form that it wants to make it. So I don't know. I'm open to it, but I haven't as yet seen it help the people that I've observed.
Any value in some of the adjunct tools like sauna, which I could see on one hand potentially could have some benefits, on the other potentially could lead to some redistribution. So interested in whether or not you think that is potentially beneficial or risky.
I think that's a very, very important topic, and I'm very pleased that you brought it in. Again, when we talk about what our bodies over 1 million years have been doing, microbiome we've developed for 1 million years, in conjunction, all the organisms in unison. They work together. They're trying to keep us alive, keeping themselves alive. Our bodies were designed to do all these healthy things. One of the ways that our bodies have detoxed for many things is sweating. And that's why you have, many cultures, Swedes, Russians, and many of the Aboriginal Native Americans have things like sweat lodges, because it works. And for gadolinium, it actually works very well. I prefer just conventional sauna, but this is the kicker. Some people, and what is a percentage? It's at least 10% of people who have GDD have lost the ability to sweat, because gadolinium inserts itself in place of sodium in the sweat mechanism. And as a result, it has acted like a true saboteur. So people have lost the ability to sweat. So if you can't sweat and you undergo sauna, you will make your condition 10, 100 times worse. So you have to be, again, understanding these things and the steward of your own health. So the sweating, I think if you're sweating, if you can still sweat, it's a good supplement, but be careful with most things. And that's why we also start low with chelation and move up. Start small. Whatever it is you're doing, start with lesser amounts and see if you tolerate it, and then increase. And I don't like people to combine sauna at the same time as chelation. So, if you're going to do sauna, which if you're sweating, I think is a good idea. But maybe if you're on a schedule where you're chelating every 3 weeks, maybe the middle week, You can undergo sauna, but take it easy. 5-10 minutes to start, see how you do, and increase a little bit. But don't go, because there's a tendency for many people to, once they start feeling well with GDD, with chelation, to start wanting to do things like extreme exercise. And I tell them, don't do that. Because again, getting back to complicating factors, a number of people have done like marathons before or after extreme exercise. And again, anything that's going to put your body at stress. Imagine, your dendritic cells are showing, gadolinium to your T cells. But if your whole system is stressed up because of extreme exercise, it's like you've introduced it when there's 100-mile-an-hour wind going on. So yes, of course, sometimes it's not going to react correctly. It's going to react to cause, hey, I don't know what this is. Let's go crazy. So no extreme exercise around the time of getting a gadolinium injection. The other thing that's useful, that maybe I'm saying this for the first time, and I want to say something else for the first time here, because you did bring it up, is, people think, oh, I'm going to get a gadolinium contrast agent. I'm going to drink a ton of fluid to get it all flushed out. I think what happens, if you think that your kidneys, maybe you're excreting 1.5 liters of urine a day, maybe a quarter of your blood volume. If you're now excreting 4 liters a day, which is almost your full blood volume, what your kidneys, and this is now a theory that I am not convinced about. So everything else I've told you to date is a theory that I'm very convinced about. But my theory is that your kidney has to make shortcuts. It has to save the sodium and the magnesium and everything else in zinc. Otherwise, you would die. So it has to save all these cations. I think what happens is that it just grabs all the cations. So when you think, hey, I'm going to get rid of all the gadolinium, it's actually going to save the gadolinium too, because it's saving everything else that's a cation to keep you alive. So my recommendation to everyone, chelation or with getting a gadolinium enhanced MR, drink a little bit more than you normally would, but 20% more, and certainly not 4 times more, because you may be doing more harm than good. Everything, again, with the Goldilocks principle. And I really like what you mentioned about CT and ionizing radiation. And this is, I'm surprised that I haven't really mentioned it to people, but we did actually some research now, maybe going back 20 years, with an agent which is an antioxidant, and looking at double-stranded DNA breaks with radiation. And a strong antioxidant does diminish double-stranded DNA breaks. So to take a potent antioxidant, maybe 4 hours and again 1 hour before a CT, makes an enormous amount of sense. And I feel badly that I haven't actually said that before, but it would make an enormous. So you mentioned one agent, ginkgo is something also that is a very good antioxidant. It's cheap, easy to come by. Amaramide is supposed to be a highly, highly potent antioxidant. The only thing I'm concerned about is being too antioxidanated. But, as a one-time shot before a CT, that makes a lot of sense to me. Anything that will diminish the amount of oxidative damage to your DNA makes a great deal of sense,
Would you also potentially want that antioxidant support around the time of the DTPA IVs or no?
Well, again, I don't know what cations they contain and how they may. And what I currently favor, because it's sort of the traditional approach. Now, as I said, I'm thinking about other more radical approaches. I very early on, published more radical approaches. I wasn't sure they were that great as far as DMARD type drugs. But now I'm thinking again about a reduced homeopathic amount of a particular DMARD drug that maybe we'll talk about in the future. But I'm just now contemplating it. But I think the combination of steroids and antihistamines, which has been used for acute hypersensitivity reactions, for everything from migraines to terrible poison ivy, It's something that's been used millions of times and it works well. It works well with this, that unless there's a problem, and sometimes there's a problem, I don't want to mess with something that works. And the other thing, Scott, that I'm in a different situation than basically everybody else, is that because I'm so recognized as a spokesperson for all this, I'm sort of the target of everybody's concern, the companies, of radiologists. So I have to avoid anything that may look like Gone Giuliani. I have to make sure that what I'm doing is scientifically sound and has been used and not something that sounds crazy.
So what's the average duration of treatment for someone with GDD, and do they often fully recover?
Generally speaking, I describe for every one gadolinium injection, you need a minimum of 5 chelation sessions spaced. Usually we use 3 weeks apart to allow some re-equilibration. That helps getting the gadolinium out. But once you start introducing complicating factors, then it increases to an unknown amount. If you've had one GBCA generally, and you're someone, for instance, people who have like a small meningioma in the brain that really doesn't affect their immune system. So one gadolinium injection and this, or they had headaches, but otherwise no immune reaction, no Lyme, no nothing else. One gadolinium, 5 chelations, 2, maybe 10. If you're better after 8, stop when you feel well enough. And if your re-equilibration gets bad, then we come back. So nothing lost. So it's usually 5 for every one, with the unknown, the extent of complicating factors. So I tell people, follow what your body is telling you. If at 3 weeks after the last chelation, the re-equilibration is minimal, let's think about stopping. And if it happens that the re-equilibration keeps escalating, you're thinking, I'm as bad as I was to begin with, nothing good has happened, I tell them, don't panic. We've got a lot of gadolinium out of you. You're just getting re-equilibration. It just means we go back to chelation and it won't be that much more. And I have a number of people who chelate maybe 5, had one gadolinium injection, chelate 5 times. After a year, symptoms are coming back, they come back for 3. If you think about it, of course, the re-equilibration keeps going and going over time. So after a year, they've now re-equilibrated enough gad back to skin and back to brain. Brain fog's getting a little bit bad. Maybe they're getting pins and needles again. But again, there's so much less gadolinium you had before, you're not going to need more than a couple to get you better. And I'm thinking ultimately it may be just using an oral agent, and instead of a multivitamin or something else, you're taking oral hope.
And each of those IVs, the 5 IVs per one gadolinium, those are about 3 weeks apart. Is that correct?
Right, generally. So again, there's some nuance to it, but that is sort of the best number.
So tell us about how people can consult with you. Where are you located? Do they need to come see you in person? Can you do virtual support? And do you work with kind of guiding people's practitioners in their local area if they are someone that's dealing with GDD?
Well, regarding the last point, as we're doing this presentation, I'm guiding another patient at another center. So immediately at this time, this is happening. So I told them, you can't speak to me during these hours because I'm doing this podcast. But today I'm doing that. So because the reality is this. The reality with this disease, and this is what I find so heartbreaking, is that most people are financially destitute because of the brain fog and maybe the physical disability. They can't work anymore. And insurance doesn't recognize this for the most part as a disease. And the government, now it's changing because there is now a ICD-10 code for gadolinium. It's changing, but it's changing slowly. So, and then many people have gone to other centers, and it seems to be amazing, huge centers that would have seen a number of these patients, but they come away with long COVID. This came on when I had gadolinium. So many people have paid $50,000 in extensive investigations for lupus, for rheumatoid arthritis, and so on. So by the time they come to me, they don't have a job and they've already spent $50,000. So it ends up that there will be a number of people who, maybe because they're too sick, I will help manage them wherever they live. So if they're in New Zealand or Egypt or whatever, or India or Turkey, I will work with their, and usually I have to charge because in my time is worth something, right? So, but I like to have people, if they can, come here for the first two chelations. I tell them, listen, I'd like you to come here to North Carolina, to Carver, North Carolina for two chelations. I'm most experienced with making the diagnosis of this. I can get you on the regimen. And if for any number of reasons you want to go back home and for treatment, I can also work with your treatment. And if you don't have one, look up places that are integrated practices close to you. Many of them are probably dealing with EDTA, but I can instruct them where to get the DTPA. I can also give them my regimens and so on. But again, this is time consuming, so I do charge, I would say, a nominal amount for this. But a lot of that is going on. And so the downside is funny because, people ask me, what is our success rate? And I would say it's very high. The problem is a lot of people, again, because of the cost, come here for a couple of sessions and then go back home, and I lose touch with them. Now, some of them I have enough information so I can tell, are they 80% or so better? Some I have just lost, and I also don't know what kind of treatment they've had. So if they haven't done well, I can't say, well, it's because this didn't work, because I don't know if they've done what I wanted them to do. And so I'm a little bit stuck that way. I know that if people stay with me, we can get them, a lot better. I would say that our numbers are probably 30% are near cured. You're never fully cured. You're near cured, because it ends up being a bit like, I tell them, listen, it's going to be a bit like the herpes virus or like the varicella virus, that under moments of stress, you're going to have some flare. But the good news is that you'll realize, hey, I got to calm down. So use it like you would, these with these other things, and you'll get over it. But I would say that, in my hands, if people had enough money to chelate, 80% would get to 80% or near cured level. Never 100% cure, but that's as good as it gets. And I also tell them the other silver lining is now you have to be attentive to your health, which you've never had to be before. I'm telling you, you have to eat properly. You have to do exercise. Maybe at times you can do a lot. You have to do things that move your joints, like Tai Chi. So I think ultimately, many people end up living a better life and a longer life because they've had to take care of themselves, which most of us don't do a great job of.
Plus, it seems to me that if someone still has some symptoms after they've gone through the series of IVs for GDD, that some of those symptoms may not be related to gadolinium, that we talked about the fact that there's often an immune priming event. Maybe they're still living in a moldy house. Maybe they have Lyme disease. Maybe they have chronic viruses. Maybe they have long COVID. I mean, so they still potentially, it would seem to me, may need to attend to that as well as to the gadolinium to fully resolve their symptom picture.
That's correct. Yes. And as I think that you've alluded to a few times, and I think this is something that you're very knowledgeable about. I think the whole thing with mold is a big deal. And I think the problem is it gets back to what I was saying about the spinning plates. Most of us can handle most molds quite well, but you're spinning 30 plates and your system can only handle 28. You throw a mold in there. So yes, you have to be attentive to all of these additional things as well.
My last question is the same for every guest, and that is, what are some of the key things that you do on a daily basis in support of your own health?
One thing I've tried to do better is eat healthier. And so I used to like drinking Diet Coke a lot. But now, I drink, my go-to drink for refreshment is a unsweetened iced tea. And if I use an electrolyte drinks, which I will do playing tennis, I try to go with ones that have a lot of electrolytes in it. And I dilute them as well, so they're not so sugary. So Powerade, Pedialyte so I tell people, listen, with chelation, particularly with calcium, maybe it makes sense to consider your electrolytes, maybe drink some Pedialyte, but not immediately around chelation. So I do that. I try to be physically active. I try to play tennis. I try to walk with my dogs. I wish I could manage my stress better. And I think, all considering everything I'm dealing with, I do manage stress quite well, but it's unavoidable. I have no choice. I have to do this for patients and other things. So I try to manage that stress better. And I try to spend time doing things that I like with people that I like and spending time with my dogs.
Every time I think that I can't get another podcast as great as some of those I've had in the past, I'm blessed with another. And this conversation was absolutely amazing. I didn't expect to enjoy it as much as I have. I learned so much from talking to you. You are an agent of truth. I respect your bravery. I honor you for the incredible work that you're doing to minimize the suffering and struggle of so many. So thank you so much, Dr. Semelka. You are incredible.
Well, thank you for having me on your program. I actually enjoyed it a lot myself. This was a wonderful conversation.
To learn more about today's guest, visit richardsemelka.com. That's richardsemelka.com. richardsemelka.com. Thanks so much for listening to today's episode. If you're enjoying the podcast, please leave a positive rating or review, as doing so will help the show reach a broader audience. To support the show, visit betterhealthguy.com/donate. To get my newsletter, visit betterhealthguy.com/newsletters. To follow me on Facebook, Instagram, X, or TikTok, you can find me there as Better Health Guy. This and other episodes can be found on Apple Podcasts, Spotify, Amazon Music, YouTube, and Odyssey.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.